Welcome to this short presentation on intermittent auscultation. It means that listening to the fetal heart rate at predetermined intervals in a low risk labor to recognize the onset of fetal stress. However, when a midwife understands the principles of fetal physiology and then listens to the fetal heart rate based on scientific principles, it is called intelligent auscultation. So we are here to discuss the principles of intelligent auscultation. I would like us to go back to our fetal life. For 9 months, we have been immersed in a pool of amniotic fluid without a molecule of oxygen, similar to us in an atmosphere where we have 20% oxygen. But as fetuses, we have had no oxygen for 9 months. So our environment was devoid of oxygen. And we had to modify our mothers because, if you think about it, the mother has to give me oxygen, so she had to breathe faster. I had to do something to increase her respiratory rate. My metabolic heat has to be dissipated to my mother because she is my environment. So I need to do something to reduce her body temperature. I need to increase her glomerular filtration rate so she excretes all my metabolic byproducts through her kidneys. I need to change her blood volume. I need to increase the blood flow so she gives me good oxygen to grow. But I also needed to have some adaptation to prevent me from having hypoxic injury when I was immersed in a totally hypoxic environment without a drop of oxygen or molecule of oxygen in my atmosphere. My atmosphere as a fetus was only amniotic fluid. It's water predominantly. So you can see all of us did very intelligent adaptation and mechanisms to deal with this situation. We had to think about our blood flow to the placenta and to blood flow to ourselves through the placenta. How do we modify and increase our blood flow? We have to make sure that our hemoglobin has increased oxygen carrying capacity so that in a hypoxic environment, we can take that oxygen and give it to all our internal organs, especially to our brain, heart, and the adrenal glands. And when you are in a hypoxic environment, it's like being a scuba diver for 9 months underwater. We needed to modify our technology, our hemoglobin type, so that we increase the affinity for oxygen. So obviously, we did all that during our intrauterine life. We also thought the normal adult heart rate my mom has, 60 to 90 beats per minute, is not enough for me because when I'm in a hypoxic environment, I needed to pump faster to get more oxygen from the placenta and distribute to my organs which are growing rapidly. So I increased the baseline heart rate, almost doubled it compared to an adult. So I had, as you can see, higher blood flow if you look at by kilograms body weight compared to my mom. I almost had double the amount of hemoglobin compared to my mom. And I had a special hemoglobin called fetal hemoglobin, which will bind to oxygen at low oxygen tension. And when I'm exposed to stress, I needed to make sure that I got more blood from the placenta and pumped more blood to my central organs during stress. I also needed to make sure that effectively I shut down the peripheral organs to supply my central organs. So I was able to centralize thanks to the ability to produce catecholamines from my adrenal gland whenever I needed. So when you do intelligent auscultation, one of the issues that you'll be looking for closely on the partogram is evidence of catecholamine response of the human fetus. Then if you look at my physiology and compare my physiology with my mother's physiology, you will find that I am totally hypoxic. And that's why most of us call this situation as Everest in utero. If you and I go to the Mount Everest and pitch up a tent for 9 months, we wouldn't be able to survive in that kind of environment without assistance, without oxygen, etc. But look at the human fetus. If you look at the mum, 98% is the saturation of any artery, including the uterine artery. But if you look at the umbilical venous oxygen saturation, that's what gives good oxygen compared to an artery in an adult, it's only 70%. If you and I, as adults, had 70% oxygen saturation, we would need intubation, ventilation in intensive care. But fetuses are able to survive because of this higher hemoglobin concentration and a better hemoglobin that has affinity for oxygen at low oxygen tensions like here, and therefore it doesn't release the oxygen. And look at the partial pressures. Partial pressure in the mum in any artery, including uterine artery, is 100 millimeters of mercury. But look at the partial pressure in the umbilical vein, is 28. We wouldn't be able to survive this unless we had those kind of modification. So a human fetus has done enough compensatory responses, and that's why we call it FIRA, fetal, intelligent, responsive adaptation. It is not only responsive to stress, it's a very intelligent way of doing things as a fetus. Now if you go back, 9 months we have been fine because of those adaptive mechanisms, but then labor starts. What did my mom do to me as a fetus when labor started? She asked me to get out of her uterine cavity. But the only way she could push me out is by contracting the myometrium, the muscle of the uterus, to push me out. But it does have certain problems for me, because as I was pushed out, as the uterus contracted, my umbilical cord got squeezed 3 to 4 times in 10 minutes for 1 minute each. Just imagine you are a child, you are learning to do scuba diving, and you are underwater with your scuba diving apparatus, and your mum jumps in and then squeezes the tube that brings oxygen from your cylinder 4 times in 10 minutes for a number of hours. Each time she squeezes for 1 minute. She'll be taken to courts for child protection issues. But our moms did that to us in labor, but we didn't matter much because we had lots of compensatory mechanisms. And she also squeezed the myometrium, so all the spiral arterioles which were traversing the myometrium to supply the placental bed, they were also squeezed. So obviously it is very, very clear that we were all exposed as human fetuses to intermittent reduction in oxygenation for 6 to 10 hours, and that threatened blood supply to my central organs and your central organs for 9 to 10 hours, because oxygen has been cut off for 1 minute each, 3 to 4 times in 10 minutes. And if you have my species called obstetricians working in the labor ward, and we start oxytocin without monitoring the contractions, then as a fetus you are in trouble. And if I work as Edwin Chandraharan in the labor ward without any knowledge of fetal physiology, whenever I'm worried about the CTG trace, I'm going to cut the skin of the fetus, thinking that it is very close to the brain, and to look for oxygen. And if you are that fetus, you are in trouble, being managed by Edwin with very poor physiology knowledge. So we knew that as human fetuses, we were at risk of intrapartum hypoxic stress due to contractions. And therefore we invented these tools, the Pinard fetoscope and later Doppler when technology advanced, to listen to the fetal heart rate intermittently during labor to recognize the signs of fetal compromise. And when technology developed, we developed the cardiotocograph. The idea was to look at the changes in the fetal heart rate in response to the stress of contractions, the TOCO, to work out whether this baby is experiencing intrapartum hypoxic stress. Our aims were very noble when we introduced these techniques to avoid hypoxic ischemic injury, HIE, or hypoxic ischemic encephalopathy, which increases the risk of cerebral palsy and learning difficulties, and to avoid perinatal deaths as a result of intrapartum hypoxic insults. But we also had to make sure that while doing this, we should avoid unnecessary operative interventions to the mother. So it is not one against the other. We want to reduce hypoxic injury to the baby. At the same time, we don't want to overreact to fetal heart rate patterns and increase the operative interventions to the mother. When we look at medico-legal issues and poor outcomes, consistently they relate to misinterpretation of the fetal heart rate changes. They relate to failures in effective risk assessment, in classifying babies into low risk and high risk, and failures in individualization of care. These are the three key issues which are not only common for cardiotocograph or CTG, they are also common for intermittent auscultation. So the first thing about intelligent auscultation is an effective, robust risk assessment. So it involves looking at the antenatal history. It involves doing an abdominal examination to find out the amount of amniotic fluid, to look at the uterine contractions. Do we have enough intercontraction interval, time between the contraction for the baby to oxygenate himself or herself? It involves assessing the fetal heart rate and an assessment of the vaginal examination findings, so that we perform a very effective risk assessment first. And based on that risk assessment, if we have excluded all the conditions which might increase the risk of hypoxic injury during labor, so that fetus is fit for intelligent auscultation. And if we find any of the abnormalities or risk factors that can increase the risk of fetal compromise in labor, that fetus requires continuous cardiotocograph. So let's look at intelligent auscultation. The principles are very, very clear. It's only suitable for what we perceive as low risk labor. And in the first contact with the woman, please inquire about the fetal movements and record the time when they were last felt by the mother. And whenever we auscultate the baby's baseline heart rate, please document this as an average. So instead of calling it 120 to 140 beats per minute, please write down 130 beats per minute, which is an average and not a range. And we need to exclude that we are not erroneously monitoring the maternal pulse, palpate for the fetal movements, and once we feel a fetal movement, auscultate at the same time to look or hear an acceleration. Because if the baby is moving somatic muscles, that means the baby has enough oxygen to oxygenate the central organs and extra oxygen to move the muscles. We know from physiology that the moment intelligent human fetuses recognize that the amount of blood that is coming from the mom is getting less, the first thing they would do is to stop moving, to conserve non-essential activity, conserve oxygen, and conserve nutrients. And wait for contraction, and please auscultate immediately after the contraction. So the first question is, who should have intelligent auscultation? So if we have done a risk assessment, if we have identified any intrapartum or antepartum risk factors, obviously that fetus needs continuous electronic fetal heart rate monitoring. If these are excluded, then intelligent auscultation is what is recommended. And while you are doing intelligent auscultation during labor, in a low risk spontaneous labor, if we find any intrapartum risk factors, the commonest ones are the traffic light system, the red, bleeding, the amber, which is inflammation, and green, which is meconium. And if we find any of these, we need to convert them to continuous monitoring immediately. So now let's go back and look at intelligent auscultation. If we are looking for basic principles of intelligent auscultation, as I said, auscultate immediately after the contraction, because contraction means it is stress. During a contraction, the baby is going to have head compression, cord compression. These are mechanical stimuli, mechanical causes of squeezing the baby, and therefore you don't want to listen in when you know that obviously you're going to see a change, and those are mainly mechanical changes. They are not hypoxic, they are not acidotic, and therefore you wait for the contraction to go. But please don't auscultate after a contraction. Please auscultate immediately after the contraction, because that is the time fresh blood comes from the placenta, and if there is a change during a contraction, as something that the fetus feels that the fetus needs to respond, the baby is going to change the baseline in order to get more oxygen from the placenta by increasing the catecholamines and increasing the heart rate. So please auscultate immediately after the contraction. What we are trying to look for is the fetal stress response. If there is release of catecholamines as a result of something during a contraction, this human fetus has to pump out accumulated carbon dioxide by increasing the heart rate, and would attempt to get more oxygen from the placenta by increasing the heart rate. Then please listen for 1 full minute, and that is obviously to avoid multiplying error. For example, this baby has a heart rate of 120 beats per minute. But if I decide, oh, I'm a bit busy, I have 2 other women to look after, let me just listen for 15 seconds and then multiply by 4, then I get a value for 1 minute. The problem is, if I make an error of 4 beats in 15 seconds, when you multiply by 4, your error multiplies as well by 4. And therefore you have made approximately 20 beats error in the final count. And that is why please listen to 1 full minute. Document the average and not the range, because if you document the range all the time, you might miss a catecholamine surge. Because if you are documenting the average, when the heart rate is between 120 to 130, the average is 125, and therefore that's where you will put your cross on the partogram. But if you are just putting the range, when the heart rate goes from 120 to 128 due to catecholamine surge, we might miss that baby. So these are basic principles of intelligent auscultation. Now, have a look at this baby. This baby is in a very quiet state and a happy state from a hypoxia point of view, because the baseline heart rate is very stable. And if you look at the variability is normal in the segment I am showing you here, and the variability is reduced in this segment. And we know that these alternative periods of active and quiet sleep cycles of this human fetus is the most important parameter in labor. And this phenomenon called fetal heart rate cycling. So this fetus is telling you, I'm not having a hypoxic stress, I'm also not having any inflammatory stress, because I'm still showing you cycling. So if you listen immediately after the contraction, you might feel the heart rate going up a little bit, because you can see there's an acceleration happening there. And when you come back 15 minutes later, immediately after the contraction, you will get the baby in the quiet phase. So if you go back to your partogram, and if you see, the crosses are going to go a bit up and down, which is excellent, because this baby is telling you, I have got active and quiet sleep cycles, and therefore I am not neurologically impaired. I am absolutely fine. So in the partogram, the crosses have to go up and down because the babies show, just like you and I, when we sleep, we have rapid eye movement sleep or REM sleep and non-rapid eye movement sleep. And the babies also have exactly the same sleep cycles. If you have crosses flat on a partogram, then there is evidence of absence of fetal heart rate cycling. And that means this fetus has an abnormal neurological function. For example, in chorioamnionitis, you have inflammation, neuroinflammation. Just like you and I, we cannot sleep when we have sepsis or severe infection. We roll on our bed because of high temperature. In the same way, if the human fetus is unable to go into a deep sleep cycle, showing reduced variability, that baby is in trouble. So when we use these two technologies to do intelligent auscultation, we must be absolutely clear that we should not be using this contraption called a CTG machine for intelligent auscultation. It is not validated because medico-legally, if you have a CTG, here you can see the midwife has been doing intelligent auscultation, not intelligent, intermittent auscultation every 15 minutes. And medico-legally, if you have an artifact, the lawyer on the other side might argue that you had missed a bradycardia during this time if the outcome was poor. So let's get the basics right. Intelligent auscultation has to be performed by a Pinard fetoscope or Doppler and never by a CTG. So if you look at the principles behind, we know that accelerations demonstrate good fetal health. If the fetus gets into a hypoxic stress which is progressive, that's what we are trying to assess during low risk labor. The progressive hypoxia, or what we call a gradually evolving hypoxia, the fetus will show decelerations followed by a catecholamine response. And therefore in the partogram, we will find evidence of a gradually evolving hypoxia due to catecholamine response. So let's look at this situation. A midwife who understands fetal physiology will not be hearing fetal heart rate during a contraction because she is clever. She knows that during a contraction, or he or she knows that during a contraction, you are going to have head compression, you are going to have umbilical cord compression, you are going to have reduction in placental blood flow. And therefore, intelligent human fetus will show a cardiovascular response by changing the heart rate during a contraction. That's why you don't listen during a contraction. Immediately after the contraction, what happens? Fresh oxygen comes from the placenta. Carbon dioxide and metabolic byproducts are leaving the placenta, and therefore a clever midwife, he, she or they, would listen immediately after the contraction to look at fetal response to stress. What she wants to find out is, immediately after the contraction, do I have enough evidence to show the brain and the heart are well oxygenated? Do I have any evidence of a catecholamine response? That's what a good midwife would be looking for during intelligent auscultation. You can see here, immediately after the contraction, this human fetus is showing the midwife there is no evidence of any catecholamine response. Some midwives, not all of them, when they fail to understand fetal physiology, very sad, they are supposed to be promoting normality, they panic about these cardiotochographs and they call an obstetrician requesting an intervention, calling it a pathological or suspicious CTG. But a midwife who understands basic physiological principles will not be calling an obstetrician when she sees a or he, she or they see a CTG like this. You know why? Because she knows that if she has done intelligent auscultation on this fetus, none of these decelerations would be heard because they are happening during a contraction. And immediately after the contraction, the fetal response has been perfect. However, if I am a midwife working in any labor ward in the world without such basic knowledge of fetal physiology, I fail that woman and that baby. What do? Instead of looking in between the decelerations to assess fetal response to stress based on physiological interpretation of CTG, asking the question, how is this baby doing? I call an obstetrician asking for an intervention. So here you can see, when we move from pattern to physiology, the principles are the same whether we use intellgent auscultation or cardiotachograph. We have to understand the mechanisms of intrauterine fetal stress. We have to determine the response of this baby to ongoing stress. We should be able to differentiate fetal compensation from decompensation and understand the features of non-hypoxic cause of fetal compromise. And most of all, we need to make sure at the beginning of labor, we exclude pre-existing fetal compromise. And during labor, we always ask the question, how is this baby? How is this fetus? So we discussed in the beginning how a human fetus has done intelligent adaptation to a hypoxic environment. But during labor, they are going to be exposed to hypoxic stress due to contractions. So what do we do as adults when we are exposed to hypoxic stress as a contraction in life, running, jogging, swimming, going to the gym? We increase the rate and depth of respiration. We increase the oxygenation to protect the myocardium. Otherwise, when you run, if the heart has to pump without enough oxygen, that myocardium will go into anaerobic metabolism, produce lactic acid, and it will stop working. We'll have a cardiac arrest. So what do we do as adults, as children, as toddlers? The moment we increase our hypoxic activities, we increase the rate and depth of respiration. Imagine then you are a fetus underwater. You are exposed to hypoxic stress now because your placenta is not giving enough oxygen. Your cord is getting squeezed. Placental blood supply is getting cut off. If you keep pumping the heart when there is no oxygen coming, you will develop anaerobic metabolism in the myocardium and you will die inside. And therefore, what did you do? You were clever. You are intelligent. You invented decelerations. So decelerations are physiological compensatory responses of a human fetus to deal with intermittent hypoxic stresses. They are not abnormal, they are not pathological. In the same way, if I go to the gym and breathe faster because I'm doing a gym exercise, you wouldn't expect a clever gym trainer to pull me out of the treadmill, forcibly intubate me and ventilate me because they are worried about increased respiratory rate. However, if I go to the hospital with sepsis and it's a pathology and I increase the respiratory rate because of sepsis, they would give me oxygen by mask. In the same way, the vast majority of human fetuses, when they are exposed to hypoxic stress, they mount a physiological response. And we should not be treating physiology as pathology, increasing the cesarean sections, increasing vacuum forceps deliveries, increasing episiotomy rate, increasing perineal trauma rate, increasing the rate of accreta, increta, percreta, increasing the rate of uterine rupture. And that's what sadly we have been doing. Recognizing fetal stress as distress, by totally changing our mindset, we have forgotten human physiology. So intellgent auscultation is about understanding fetal physiology. So here you can see this fetus, this woman is coming to you at 40 weeks plus 6 days, almost 41 weeks. She is low risk. She is coming in a spontaneous onset of labor. You are trying to do intellgent auscultation. If you ask yourself to ask a question to the midwife who does intermittent auscultation, is this baseline normal? She would say yes, because it is between 110 to 160. That's what guidelines say. But if you ask a midwife who does intellgent auscultation, he or they wouldn't say it's normal. They would be asking a question, what is the normal baseline heart rate? Because 110 to 160 is for human population of fetuses, not for this fetus. It is for the population. And therefore, if you see fetuses who are relatively preterm, around 36, 37 weeks, the baseline heart rate will be in the upper limit of normal. Whereas fetuses who come after 40 weeks, their baseline heart rate is going in the lower limit of normal. And that's because we know from medical school and midwifery school that the vagus, the parasympathetic nervous system, gets progressively stronger after 34 weeks. And therefore, the baseline heart rate is not the same at 36 weeks as compared to 41 weeks. My good friend Diogo's group from Portugal did a very good study of 11,000 human fetuses, and they were able to show human physiology in action. You can see as the gestational age advances, due to progressive maturation of the parasympathetic nervous system, there's a progressive fall in the fetal heart rate in accordance with advancing gestation. So you can see at 41 weeks, we cannot accept anything more than 140 as normal. And that's why midwives who do intellgent auscultation would ask the first question, is this baseline heart rate I am listening to appropriate for the gestational age of this given fetus I'm looking after? Whereas midwives who do intermittent auscultation, they would just write a number, 150, normal, because it is between 110 to 160. And that makes a huge difference to a human fetus. So let's look at this. 41 weeks is the baseline heart rate. If you find it as 155, if you do intermittent auscultation, that's a normal baseline heart rate, because you know why? It's between 110 to 160. Very simple, tick box. A high school student can do intermittent auscultation. But an intellgent auscultation has to be done by a qualified midwife who learns science. And a qualified midwife who learns science would ask the first question, is this baseline I am listening to appropriate for the gestational age of this fetus? And she would say, this is not normal. Intermittent auscultation midwife would say this is normal. Intellgent auscultation is not normal, because with advancing gestation, we all know that the baseline heart rate comes down due to vagus. At 41 weeks, based on scientific evidence, published data, we cannot expect anything more than 140 as normal. And therefore, the midwife who understands physiology would call this fetal heart rate 155 at 41 weeks as abnormal. And that makes a huge difference to a human fetus in terms of their well-being, in terms of their ability to go to normal school, not ending up on a wheelchair. It makes a huge difference. So you can see this CTG. This will be, if you are doing normal suspicious pathological classification, either it will be suspicious or pathological, depends on which suspicious eye looks at it. But those who understand fetal physiology and do intellgent auscultation will not be picking up any of these decelerations. And the midwife would look at the baseline heart rate to determine whether it is appropriate for the gestational age. And these are the true normality promoting midwives. But sadly, in life, there are abnormality promoting midwives who are sadly working in some labor wards without understanding basic human physiology. And therefore, they are going to look at this CTG and call an obstetrician asking for an intervention. And the babies are saying, don't be crazy. These are all baroreceptor decelerations. See how quickly they are dropping. They are coming back quickly. There's no acidosis. There is no hypoxia. And look at the features in between the deceleration. I'm absolutely fine. But if I'm a midwife who does not understand fetal physiology, I would call this CTG as pathological, call the obstetrician, ask for an intervention. So I convert a normal physiological situation into a pathological situation due to lack of knowledge and increase intervention, working in conjunction with an obstetrician, Edwin, who doesn't equally understand physiology. It is going to come to light very soon because the damage we are causing to women and babies is enormous. They are going to find out that fetuses only showed stress responses. Decelerations they indicate fetal stress response to protect their heart, myocardium. They are reflex responses. But when that is combined with midwifery distress due to lack of knowledge, obstetrician's distress, and lack of basic physiology knowledge, then it is classified as fetal distress. We go and tell the woman, your baby is in distress, and that's a lie. Babies are never in distress. They are exposed to stress. Just like in the gym, if you go and breathe faster and if you are tachycardic, no physician can come and take you to the hospital saying you are in distress. No, you are exposed to hypoxic stress. We cannot stop all the marathon runners and forcibly intubate them because we don't understand fetal physiology. They will sue us if we do that. And this is what we are doing to women and babies. We are converting normal physiology into pathology. Whereas a good midwife who understands fetal physiology would not panic about these CTG traces because on intelligent auscultation, she will know that she will not be hearing them. But she knows what will this fetus do if the hypoxic stress increases. She knows from the knowledge of basic fetal physiology and human physiology that when we are exposed to stress, we need catecholamines. And therefore, that is going to increase the baseline heart rate. So from 120, you can see the baseline heart rate has gone to 160. When she does intelligent auscultation, this midwife will pick this rise in the baseline. And when she puts that all together, she knows this fetus is having a gradually evolving hypoxic stress. And when she plots it on the partogram, you can see the baseline heart rate would start to increase. A midwife who does intermittent auscultation with no knowledge of fetal physiology will call this normal. You know why? It is between 110 to 160. But a midwife who understands fetal physiology and does intelligent auscultation will convert this into continuous monitoring because for her, there's a 10% increase in the heart rate for this baby compared to what she heard before. So she does individualization of care. She compares the same baby to the same baby. Whereas those who work without physiological knowledge, they compare this baby with the population of babies in the world and they miss this baby. This is what is happening sadly. So this is catecholamine surge. If this midwife was doing intelligent auscultation, she would pick it up. She would not be picking up any of those ongoing decelerations. She'll be asking, why are these contractions in low-risk labor too much? What is causing excessive contraction without oxytocin? That is the question she'll be asking. A midwife who works without knowledge will call it a pathological CTG. In life, there's nothing called pathological CTG. It's cooked up by some obstetricians across a guideline group. There's nothing called pathological CTG. This is the baby with an evolving hypoxic stress with catecholamine response. All we need to find out is why is the stress getting so large in a low-risk labor. It is a gradually evolving hypoxic stress. So you can see this is abnormal, and instead of counting the contractions, because that's what guidelines do, midwives who understand fetal physiology, they don't count the contractions because they know it's useless. They look for intercontraction interval because that is the time the human fetus has to get fresh oxygen from the placenta and to release the carbon dioxide. If I don't understand physiology, I simply become a counter of contractions during labor. If I understand fetal physiology, I know that contractions are much more than frequency. The properties of any muscle contraction includes frequency, duration, strength, and basal tone. Sometimes you might only have 3 contractions. They are very strong. Sometimes you have only 3 contractions, but they're lasting for 1.5 minutes, and that is uterine hyperstimulation. We cannot be so simplistic and nonsensical by classifying hyperstimulation based on number of contractions when there are several properties that affect the human fetus. So imagine if you are a fetus here, you need fresh oxygen to the brain, but these contractions have increased their basal tone. So between the contraction, if you don't have enough oxygen coming in to supply the brain, you are going to have increased risk of hypoxic injury. In spontaneous labor, if you have myometrial irritability, strong uterine contractions, that you should exclude 2 key features, chorioamnionitis and your concealed abruption. And therefore, this fetus needs continuous monitoring. Otherwise, we'll end up with a poor outcome. So intelligent auscultation is all about individualization of care. So in first stage of labor, what should you do? The first question we ask is this baseline heart rate appropriate for the gestational age of this baby I'm looking after? If you look at here, a good midwife would listen immediately after the contraction. She would find, or he would find, or they would find a very good heart rate which is very stable. There's no evidence of any catecholamine surge. Midwives who understand physiology always determine fetal response to stress, whether they are doing intelligent auscultation or whether they are doing cardiotocograph. They listen immediately after. That's where the fetal response to stress. They never listen during a contraction because they are clever enough to realize that if you listen during a contraction, you will hear a deceleration because the head is squeezed, cord is squeezed. But some midwives who work in the labor ward, they fail on basic physiology and they call these cardiotocographs as suspicious or pathological, asking for an intervention from an obstetrician. Whereas midwives who understand fetal physiology, they are allowing the labor to continue at homes or at birth centers in low-risk labor because they know what to do. So you can see this is the problem in our specialties. There are normality promoting midwives who are doing the right thing for the woman and the baby. They listen immediately after the contraction. When they are doing intelligent auscultation, when they are working in the labor ward, they look at the features immediately after the contraction. Whereas the abnormality promoting midwives who are working sadly without basic physiological knowledge, they are calling the obstetrician and asking for an intervention. And they are blaming the obstetricians for increasing the cesarean section rate when they shouldn't have asked them to come into their room in the first place. So you can see here, in between the contractions, immediately after the contraction, that's where we had to assess fetal response. If you are a human fetus, as the labor advances and the contractions are getting stronger, you will have cord compression because you may have ruptured your membranes and the amniotic fluid has been leaking. So the cushioning effect of amniotic fluid is not the same at 3 centimeters compared to 8 centimeters because you have been leaking your amniotic fluid. And the contractions are much more stronger. They are forcibly compressing your cord. You will show physiological responses which are decelerations. They are quick, and therefore those of us who understand fetal physiology, they are baroreceptor mediated, quick decelerations. They are not associated with hypoxia and acidosis. Until such time that human fetuses are born with wireless technology, where they receive the oxygen and their nutrients without the umbilical cord, cordless, we will have these ugly decelerations. 85 to 90% of all decelerations we get during human labor are these ugly decelerations, baroreceptor decelerations. In the past, we used to call them variable decelerations because they look different to each other. And decelerations, once you understand fetal physiology, you will realize they are cardioprotective responses. They are good. They are fetal stress responses. We should not treat stress as distress. We should not go to the gym and pull all the people who are exercising with high respiratory rate to force them to have oxygen by mask or intubate and ventilate them because we don't understand human physiology. So in the first stage of labor, please listen immediately after the contraction for 1 minute, once in every 15 minutes, only because the stress is much less, the contractions are less stronger. Whereas once you come to second stage of labor, imagine you are this fetus. Your mom is now pushing during second stage. When she is pushing, try it, you can't breathe. So your mom is not getting enough oxygen. Her oxygen level falls down, your placental oxygen level falls down, and when she does Valsalva maneuver, her venous return is less, their cardiac output is less, your placental circulation is less, and your head here is going to be really squeezed into the bony pelvis. And when you squeeze the head, we all know intracranial pressure increases, and therefore carotid circulation falls. So you, as a human fetus, you and I, because the contractions are also stronger, you're getting squeezed, the umbilical cord and placental blood supply gets cut off, we are all at increased risk of injury in second stage of labor. And that is why we need to monitor them more carefully, more closely during second stage of labor. The rate of fall in pH, if you take the first stage of labor, it falls at the rate of 0.01 every hour. But in second stage of labor, that is 10 times. That's 0.1 every hour. So second stage of labor, principles are the same. Please auscultate immediately after the contraction for 1 full minute, but once in every 5 minutes, because the stress is much, much higher. So you can see, if this is the baby you're looking after, a good midwife who understands physiology, if you are looking at this cardiotocograph, you will never call an obstetrician, because you know that these are all baroreceptor deceleration. They are quick to fall, quick to come back, and if you are doing intelligent auscultation, you will not be hearing anything, any of these decelerations, and therefore you would not panic when you see a CTG. In the first stage of labor, if you take 0.01 every hour, okay, so if the pH is 7.28 here, in 10 hours it will fall to 7.18. because it's 0.1 in 10 hours. But once you come to second stage of labor, that rate of fall in pH, because of the increased frequency, duration, strength of the contraction, happens at much higher rate. It's 10 times faster, and that's why we need to be very, very careful. And this study was published in the UK long time ago, about 30 years ago, and it's an excellent study. They wanted to find out what is the effect of uterine contraction on fetal oxygen saturation. So when the contraction begins, you can see Mama Nature protects the babies by giving them a bolus of oxygen. So you can see whatever oxygen that is present in the placental pools is pushed to the baby. It's like taking a deep breath before you jump into the water when you want to dive. And that's why the fetal oxygen saturation increases at the beginning of contraction. But as the contraction persists, there's a gradual fall in the fetal oxygenation, and the lowest fall is 92 seconds after the peak of the contraction. So remember, when you are telling the woman, darling, your contractions are going away, that's the time the baby is feeling it most. But when the contraction goes away, it takes another 90 seconds for the fresh blood to come to the placenta and to get all the carbon dioxide out, for the fetal oxygenation to return back to pre-contraction level. And that's why in the physiological CTG guidelines, we have given you 90 seconds as the intercontraction interval. And that is based on this research evidence. So when you look at the fetal oxygen cylinder, remember, if we have to survive labor intact, this is what we need. Once the contraction starts and the cord gets compressed, we are going to be in trouble. But take a step back and think, if my placenta is not good enough, my mom has preeclampsia, I've got infarction thrombosis of the placenta, I've got poor placentation in growth restriction, and that's the time I'm going to feel it. If I have chorioamnionitis with villi being swollen due to inflammation, I can't do effective gas exchange. If I have diabetes, if my mom has gestational diabetes, due to terminal villus hyperplasia, my villi are not mature, they can't do gas exchange. And therefore, I'm going to rapidly go into hypoxic injury if you're not careful. So a good midwife, a midwife who promotes truly normality by understanding fetal physiology, will listen immediately after the contraction, because she knows, or he knows, or they know that during a contraction the fetus is exposed to stress. Imagine someone comes and squeezes you. You will have stress. If someone squeezes my ball patch, I'll have stress. Babies have stress because their cord is squeezed, the head is squeezed. Mom is pushing, you can see. So she will never listen during a contraction. A good midwife will listen immediately after the contraction. She is looking for fetal response to stress. That's what a good midwife does. Well, midwives and obstetricians like me who don't understand any physiology, we panic about decelerations and call names: normal, suspicious, pathological, atypical, typical, complicated, uncomplicated. Babies are laughing at us. To see, Edwin, how can you work in the labor ward without basic understanding of physiology? Why can't you learn from a normality promoting midwife who understands fetal physiology and listens immediately after the contraction? But, a good midwife would be looking for a catecholamine surge at this time, because as this contraction gets worse and worse and the mom is pushing, human fetuses need more oxygen. And they have to release catecholamines to get more oxygen. And you can see baseline heart rate is going up. If you are a non-physiological midwife or an obstetrician, you would call it normal because it is still between 110 to 160. But if you are a physiological midwife, you would call it abnormal because the baseline has gone up over 10% for this fetus. So you can see in the partogram, a good midwife would immediately recognize. And then she will stop the stress. Unless the head is visible, she will stop the stress by stopping the contractions, by asking the woman not to actively push during a contraction to take away the catecholamine response. Then he or she or they would examine the woman to see how high is the head. If the baby is going to come out in the next 10 minutes after giving rest, she may want the woman to push every other contraction instead of every contraction to reduce the stress and to ensure a normal birth. Whereas if the head is very high, occipito-posterior, that baby needs transferred for continuous monitoring and further interventions. So always reduce the excessive activity, because if we don't do that, there will be a crash and then we monitor the wrong person. This one is, you can see these decelerations are not those ugly decelerations. Intermittent auscultation is designed to pick up these decelerations. They are chemoreceptor mediated late decelerations due to a placental insufficiency. And when you listen immediately after the contraction, this is what you are expected to pick up: the slow recovery to the baseline. Because placental insufficiency is something that we need to address. Not cord compression. Cord compression is mechanical most of the time. It's not associated with hypoxia acidosis. But if you have insufficiency of the placenta, the villi are smaller. You can see when the contraction starts and when the contraction goes away, that's the time fresh oxygen has to come from the placenta to take away the stimulus from the chemoreceptors. So it takes time, delayed recovery. It's not on-off like cord compression. It is slow because there are chemicals involved. There is hypoxemia, hypercarbia, and acidosis involved. In the same way, as the contraction goes away, accumulated carbon dioxide and metabolic byproducts take time to leave, and therefore it takes a slow recovery back to the baseline. Finally, we need to also talk about limitations. Of everything in life, there are limitations. So we cannot determine baseline variability on intelligent auscultation. We can't determine features of neuroinflammation on intelligent auscultation. We can't determine features of fetal-maternal hemorrhage or chronic fetal anemia acidosis on intelligent auscultation. Let's look at this situation. At 40 weeks and 4 days, you can see the baseline heart rate is about 110, which is appropriate for gestational age. So the baseline is appropriate. When you do intelligent auscultation, you will write down the baseline of this fetus is appropriate for the gestational age at the beginning of labor. And you're listening immediately after the contraction. This fetus is also showing you cycling. You can see normal variability followed by reduced variability, perfectly in good condition. And this is the state of the fetus at the beginning. So you would be very happy because on intelligent auscultation, you would have found all the positive features. 2 hours later, if you look at the partograph or the CTG, you can see the baseline has increased, still within 110 to 160, but it has increased more than 10 beats and without decelerations. And that is due to chorioamnionitis. But if you are using intelligent auscultation, you will pick this baby up because not only the baseline has gone up, the crosses are going to be static because this baby has lost the phenomenon of cycling. And a good midwife doing intermittent intelligent auscultation would pick this baby up, both in the rise in the baseline and cycling. So when you are looking at non-hypoxic insults, in chorioamnionitis, there will be a 10% rise in the baseline. There will be absence of accelerations because when you are ill, when you are infected, you don't move. And there will be features of neuroinflammation, pool shark teeth pattern, zigzag and typical sinusoidal pattern. So intelligent auscultation will help you pick up the 10% increase in the baseline, will pick up the absence of accelerations because the crosses will be flat, absence of cycling, the crosses will be flat, but you will not be able to pick up the other abnormal features. So 2 hours later, if they were doing intelligent auscultation, they would have picked this baby up because the baseline has gone up by more than 10% and it is quite flat. The crosses were flat because of absence of cycling. This is chronic hypoxia for those who understand fetal physiology, and you can see the intelligent auscultation. You may not be able to pick up those shallow decelerations, but you will still save this baby because in intelligent auscultation, your first question you will be asking is the baseline heart rate higher than expected for the gestational age? Is it appropriate? If this baby is 41 weeks and you know 150 at 41 weeks is not appropriate. And if you continue monitoring, you can see there is no active sleep, quiet sleep cycle, and therefore the crosses would be flat and you would pick this baby up. And this is a very recent study, this published quite recently in 2022. You can see what we wanted to do, a group of obstetricians and neonatologists working together, applying fetal physiology to determine the outcomes. So you can see, as we would be expecting, those babies who showed evidence of chronic hypoxia on the CTG trace, they consistently showed global brain injury, and as would be expected, those with gradually evolving or subacute hypoxia showed peripheral white matter or watershed injury, and those with acute hypoxia showed basal ganglia injury. We also follow these babies for 2.8 years to look at the neurodevelopmental outcome. And you can see, as expected, very sadly, chronic hypoxia, 40% of fetuses with chronic hypoxia had poor neurological development compared to 16% in acute and subacute hypoxias. The sad thing is, when guidelines are used without the knowledge of fetal physiology as normal, suspicious, pathological, most of these babies are missed as suspicious CTG, babies with chronic hypoxia, and these babies with acute hypoxia are usually overtreated with increased interventions. This is another limitation. Those who understand fetal physiology, this is pool shark teeth pattern. If you are listening every 15 minutes or every 5 minutes, you will not be hearing them. You will not be hearing these abnormal patterns on intelligent auscultation. That's one of the limitations. But when you take a good history, most of the time, if there's a sudden fetal-maternal hemorrhage, the woman will come with reduced fetal movements. In the same way, when there's a pre-terminal CTG, which can be an end stage of chronic hypoxia or chorioamnionitis, the woman would come with reduced fetal movements. So if you take a good history, you will pick these up, but not on intelligent auscultation. Again, this is chronic fetal anemia and acidosis. You will not pick this up on intelligent auscultation, but a good history at the beginning of labor would help you to identify these cases. Flat baseline. So the last bit is on this phenomenon of overshoots, because you can see here when you have contractions and cord compression, you expect to see a drop in the heart rate. That is physiological responses. But if you see the umbilical vein being squeezed longer than the umbilical artery, either due to cord compression, cord around the neck, etc., you would find that the immediate restoration of oxygen to the brain doesn't happen. And when you listen immediately after the contraction, the baby has to do mount a compensatory response to increase the heart rate. Just like in postpartum hemorrhage, when there's a low blood volume, the woman has to increase the heart rate to perfuse faster. You get a tachycardic response. In the same way, if the umbilical vein is squeezed for a long time, the fetus doesn't get enough blood volume from the placenta, but the arteries are open, they pump the blood back, there's relative hypovolemia, and therefore you'll have these overshoots. And if you are hearing an accelerations immediately after the contraction, that is totally unphysiological. Babies might accelerate some time after the contraction, but not immediately after the contraction, because they need to perfuse the vital organs first. So if you are hearing on intelligent auscultation large amplitude accelerations immediately after the contraction, that fetus needs continuous monitoring. And that's because the fetal heart rate overshoots due to sustained compression of the umbilical cord can happen due to a variety of conditions, including intense compression due to oligohydramnios or tight cord around the neck. Again, if you see here, this baby is showing nice cycling. You'll be active phase and quiet phase. And these will be coinciding with your fetal movements. But what would you do if you hear and you get crosses going flat for some time, because there's no variation? There's nothing to worry about, because if you understand fetal physiology, absence of accelerations, if it is chronic hypoxia, that's why the baby is not showing cycling behavior. You would expect the baseline heart rate to be higher than expected because they have a catecholamine response. So the clue is in the baseline all the time. Look at the baseline. Here the baseline. Is the baseline appropriate for gestational age? If the answer is yes, if you see flat line, forget about that baby. That baby is not hypoxic. If you have absence of cycling at a higher baseline, take that baby seriously, because it could be either due to hypoxia or acidosis or inflammation. Otherwise, the baby will wake up, and some babies want to sleep much longer. So risk assessment is important, and we need to identify all the risks before we decide whether the woman or the baby is suitable for intermittent auscultation or continuous monitoring. And finally, a good checklist is extremely important at the beginning of labor to determine that intelligent auscultation is carried out properly. During labor, if any of these risk factors operate, obviously you need to convert to continuous monitoring. And let's have a common sense approach and put ourselves in the fetus, the shoes of the fetus, and decide, if I'm this fetus, what would I expect my midwife, who is supposed to prevent hypoxic injury of my brain and hypoxic injury of my heart, to do in this situation? And let's be sensible about converting to CTG monitoring based on the risk factors we see. So thank you very much.